my name is Francheska Camilo. I will be talking about the question number 4. The question number 4 indicates that a 50-year-old patient complains of shortness of breath, swelling of the cervical veins, enlarged liver, ascites, edema of the lower extremities, previously treated for pulmonary tuberculosis, heart rate of 96 per minute, has signs of muffled, blood pressure at 100 over 80. ECG is a sharp decrease in voltage. And the question is asking about the diagnosis, the plan of investigation, and the treatment plan. Okay. For case summary, we have that the patient is a 50 years old adult presenting with a progressive shortness of breath, that the physical examination shows cervical vein distension, hepatomegaly, ascites, and leg edema, suggesting right-sided heart failure, that the patient has a past history of pulmonary tuberculosis, which raises suspicion for TB-related cardiac complication, and that the heart sounds are muffled and the ECG show a low voltage, indicating a possible pericardial involvement. Um, that the blood pressure is 100 over 80 and demonstrating a narrow pulse pressure consistent with impaired cardiac output. For diagnosis, we have that the most likely diagnosis is tuberculous pericardial effusion with cardiac tamponade. That this diagnosis is supported by a history of pulmonary tuberculosis and clinical signs of right-sided heart failure, that the muffled heart sounds and low voltage ECG are classic feature of a large pericardial effusion, that the narrow pulse pressure indicates a reduced ventricular filling due to external compression, and that together these findings strongly suggest that fluid accumulation is restricting normal heart function. For initial investigations, we have the echocardiography is the primary diagnostic tool because it confirms the presence and severity of pericardial effusion. The chest X-ray may show a classic water shape cardiac silhouette in a large effusion, that ECG typically demonstrate low voltage complex in patients with massive pericardial fluid, and that the blood tests, including CBC, CRP, and liver and renal function panels, help assess systemic impact and underlying inflammatory activity, and an HIV testing may be indicated or required because this disease is associated with tuberculous pericarditis. With TB specific investigations, we have the pericardiocentesis with fluid analysis is essential to confirm the tuberculosis as the underlying cause. That the laboratory testing should include the AFB smell and culture, the ADA levels, um, and PCR for Mycobacterium tuberculosis, and that the fluid cytology, protein, and the LDH values provide additional diagnostic information, and that the CT or MRI of the chest is useful when evaluating for chronic complications such as pericardial thickening, and that these imaging studies help to determine whether constrictive pericarditis has developed. For treatment plan, we have the urgent pericardiocentesis is required to relieve pressure on the heart in cases of cardiac tamponade. Um, making it the first life-saving intervention, and that the anti-tuberculosis therapy is necessary to treat the underlying infectious cause and prevent recurrence, and that the corticosteroids may be used to decrease the inflammation and reduce the risk of progressing to constriction pericarditis. Also, we have that the diuretics are helpful after drainage to improve the symptoms of fluid overload, such as edema and ascites, and that in cases of irreversible constriction, surgical pericardiectomy may be required. And also, we have that there is no specific vaccine for tuberculous pericarditis, but researchers have investigated on experimental immunotherapy using Mycobacterium indicus pruni as an adjunct to a standard anti-tuberculous treatment. We here have a pericardial fusion of image and where we can observe healthy heart and a heart with a pericardial effusion. The blue fluid around the heart in the diagram is the pericardial effusion, and this fluid builds up in the pericardial sac and exerts pressure on all four chambers of the heart. Because of that pressure, the heart walls cannot expand normally during diastole, which restrain the filling of the chambers, especially in the right side. This compression leads to cardiac tamponate or tamponade, where the heart is squeezed and cannot pump effectively. We also have the hemodynamically. This raises the pressure inside of the pericardium, equalize the diastolic pressures in the heart chambers, and reduce stroke volume and cardiac output. The relation of the pericardial effusion of this photo with the case is that in tuberculous pericardial effusion, that is the case, the fluid accumulates in the pericardial sac. This fluid can compress the heart, leading to tamponade, which explain many cases or many clinical signs of the patient that are the muffled heart sounds, the low voltage ECG, the neck vein distension, and the poor feeling of the heart. Here we have the reference, and that's all. Thank you.